And one of the biggest series in India of pancreatic diabetes is in his name. Um, Now he was at Amruta Institute at Kochi, associate professor and then professor, and now last 10 years, more than 10 years now, I believe, 12 years, he has shifted to Pune and he is heading Chelaram Diabetes Institute. So he is a multifaceted person, not only a clinician, but research as well as the dynamism of the CEO. And now he's taken the center to where he said the center is recognized center of excellence by IDF, International Diabetes Federation. He is also editor for many journals, Indian journal, endocrinology metabolism, then thyroid research journal, Indian journal, and some international journals as well. So I would request Dr. Unni to come for his talk.
Thank you for that warm introduction. Even without the slide, with a slide, you couldn't have introduced me better even if you had a slide. You spoke so much about me. And it's, I think, 12 years in Pune. I'm really humbled with the love and affection of our community. My topic today, as Dr. Tulpule said, is about the science of weight loss, and because of the medical treatments that have made obesity today into a treatable disease. It was not considered a treatable disease, but today it is considered to be a disease and a treatable one medically. So this is a paper we published on the occurrence of obesity in Pune. This is our own data, and the data is of 29,324 patients. Let me just get the laser pointer. Yeah, 29,324 patients. And what we found is that the overall prevalence of obesity is about 26% if you take the Asia Pacific BMI cutoff. In fact, this will be one of the largest studies from this part of India. And if you look at waist circumference, the prevalence of obesity will be even higher. And why do we treat obesity? Obesity, at the top you will see that obesity being a balance of energy intake and energy expenditure. But that is how obesity happens. That is not why obesity happens. Obesity happens because of a complex interplay of the brain, the gut, and the adipose tissue. This complex interplay actually tilts the balance between energy intake and expenditure. And knowing this has led to major therapies, and if you see all the therapies for obesity, they target either the brain, the gut, or the adipose tissue. I will talk about this later, and this slide shows several new treatments for obesity, but the GLP-1 is one of the most important, and I will highlight it. One of the reasons why people have looked at medical treatments for obesity is because whatever you do for weight loss, many people struggle to maintain that weight loss. It's very easy to lose weight initially, but whether they are on behavior therapy or low calorie diet or combination, after some time there is an increase in weight. In other words, it is very difficult to lose weight and keep it down. And currently the treatment gap, one of the important treatment gaps is that you have diet and exercise on one side and older drugs, and then you have the bariatric procedures, which may be surgical or, as you will hear, the novel endoscopic procedure. But between that, there was a gap that needed to be addressed. And I know that there are so many molecules coming for obesity, and as a disclosure, I must say that we are also doing clinical trials on many of these molecules. But I will talk about only 3 of these molecules in the interest of time. I will talk about setmelanotide, I'll talk about semaglutide, which is already there, and I'll talk about tirzepatide. Now, the main center for the appetite regulation in the brain is our hypothalamus. We eat because of the hypothalamus. We feel full because of the hypothalamus. And the hypothalamus has got this area called the arcuate nucleus. The arcuate nucleus is a center which controls the appetite. But the arcuate nucleus is not a single nucleus. It's a collection of hypothalamic neurons. And the arcuate nucleus has got some good neurons called the POMC neurons, and the bad neurons. These are the AGRP and neuropeptide Y hormones. So the balance of your appetite is a balance of these two hormones. So you have the good hormones, which is the pro-opiomelanocortin system, the bad hormones, which are the AGRP and the neuropeptide Y. So how it works is, you can see that these leptin is a signal of the fat. Do we have a pointer? Pointer. So leptin is a signal of the fat stores in the body. Once the fat stores tell the brain, it tells the hypothalamic POMC system. POMC stands for pro-opiomelanocortin system, and that binds to this receptor called the melanocortin 4 receptor and leads to weight loss. So how it works out is that these signals keep on telling people, don't eat, don't eat, don't eat, don't eat, don't eat. So when we put on weight, when the fat reaches a critical threshold, the hypothalamus gets signals, don't eat, don't eat, don't eat, and those signals actually come from the POMC neuron. If you look in detail, this is even more complex because these signals can get blocked, and any block in the signaling system, in this POMC and melanocortin signaling system, can lead to increased appetite, decreased energy expenditure, and increased body weight. Now I come to a case which is, thank you. So this is a 18-year-old gentleman. The BMI is 52 kilograms per meter square. And this is a boy with obesity-related various complications and acanthosis nigricans. He has Bardet-Biedl syndrome. I did have a picture of this patient, but I didn't show it because the meeting is also being streamed, so I did not want to show the picture, being a young gentleman. And you can see that he is diagnosed to have Bardet-Biedl syndrome. All the lifestyle measures have failed, and he is not interested in bariatric surgery. Now earlier, in these cases of hypothalamic obesity, there was no cure. We would just say manage, diet and exercise and manage. Even semaglutide, Mounjaro, we would be afraid, worried about prescribing to very young people because we were not sure about the evidence. But now there is a new treatment beginning with S, and I'm going to put forward an MCQ which I will myself answer. And the MCQ is, what will you advise him? The drug beginning is with S is semaglutide. Treatment could result in inappropriate erections or sexual arousal. Treatment can result in lightening of the skin. The injection can be given weekly. So this is an injection called setmelanotide, and this injection ushers a new era for treating children or young adults or people with refractory hypothalamic obesity, like the Bardet-Biedl syndrome, like we must have read about the Lawrence-Moon syndrome. So this drug targets the hunger pathway. It targets the hunger pathway and makes people eat less. It is now indicated for a host of hypothalamic diseases, not just Bardet-Biedl syndrome. So just to illustrate how it works, I've created a small slide set. So imagine this is your brain, and this is a neuronal pathway of the brain. And in this neuronal pathway, there are a lot of like these trucks are carrying information, the neurons are carrying signals to the brain. What is the signal telling? Signal is telling, don't eat, don't eat, don't eat. That's what the signal is telling. But what happens if there is a mutation in this pathway? There is a red light, or the traffic gets blocked, and all the trucks are blocked now. Now when all the trucks are blocked, the signals are not getting through to the brain. So the signal, don't eat, don't eat, don't eat, is not reaching the brain. So what happens? The signal that brain is getting is eat, eat, eat. So the patient starts gaining weight. So how these drugs work? Setmelanotide, it's like a nice little traffic policeman which now changes a signal from red to green. Now the signals know that they can go through. So the signals go through very nicely, and you will see that these signals tell the patient again, don't eat, don't eat, don't eat, and people lose weight. Now the only problem with this drug, setmelanotide, let me see if my video works. Yeah, so the only problem with this drug is that these drugs stimulate the melanocortin receptor. And because these drugs stimulate the melanocortin receptor, it can cause hyperpigmentation. So pigmentation of the skin is a problem. You must have heard of, we all know that in Addison's disease, when ACTH gets stimulated, you get hyperpigmentation. Similarly, it is a similar mechanism when the POMC pathway gets blocked, that's corrected, the melanocortin stimulation is in excess, and that again cross reacts with the melanocyte receptors in the skin to produce hyperpigmentation of the skin. So again, recently the US FDA has approved setmelanotide for even pediatric children 6 years and older with syndromic hypothalamic obesity, which is Bardet-Biedl syndrome, and probably the first drug in the world to be approved for syndromic hypothalamic obesity. And generally, people lose about 8% of their BMI within 1 year, which is pretty good for children. And therefore, it is now also indicated not just for this, but for so many mutations, PCSK9 mutations in the brain, POMC mutation, leptin receptor mutation. For all these genetic mutations, now we have a cure for children, which is setmelanotide. Unfortunately, it's not available in India, but it is available in the United States. So coming back to this boy, 18 years old, and this is a person who will benefit from this drug, and I'll answer the MCQs which I presented. The drug beginning, so the correct answer is treatment can result in inappropriate erections and sexual arousal, because these drugs influence the hypothalamus by off-target actions and can increase sexual arousal and hypersexuality. So that's a side effect of this drug. And the drug is not semaglutide, it is setmelanotide. Treatment doesn't result in lightening of the skin, it results in darkening of the skin, and the injection cannot be given weekly. It's a daily injection, but weekly I am told is in the works. So having finished that, I'll come to the second injection, which is semaglutide. Now, I don't want to stand between you and dinner, but when you have your food, you will certainly thinking that, oh, the food I eat is a little calorie rich, it's full of sugar. How will I eat it? I don't feel like eating it. I shouldn't eat it, but I want to eat it, right? I would like to eat it. Even I love eating ice creams and chocolates. So what we mentally calculate is that we'll say, okay, yesterday, maybe last week, I didn't eat that rasgulla that was in front of me, so I'll compensate by eating today. The problem is these sort of internal compensations can be extremely anecdotal and variable. We can't judge it. So these, and also there is only a few seconds to decide on it. And the third thing is you have the smell and the flavor of food hitting you continuously. So there are three aspects to eating. Hedonic, which means you eat for pleasure. Hunger, which means you eat when you are hungry. And third is heuristic. You decide to eat. That's on the frontal lobe. You have food in front of you. In a split second, you have to decide. But the pleasure part is telling you eat, eat, eat. The hunger part, you may or may not be hungry, but it doesn't matter. In that split second, people cannot make a decision. And they eat. And they eat not only that, they eat rasgulla. They may finish the liquid of the rasgulla and they finish the whole box of rasgullas. So this is a problem, and that is why you have drugs like GLP-1s which act on the brain. They take away this subconscious decision making because they overall suppress appetite. They are very similar to GLP-1s. They can be injected once a week. They reduce the appetite and they also act on other tissues, including they have satiety. So there are studies, and this is one of the studies of the step 8 in which it improved glucose metabolism. But the reason why I'm showing you is not that it improves glucose metabolism. The reason I'm showing you this is the weight loss at week 68. It's about 16 kilos. That means a 100 kilo person at the end of say a year or little more than a year is going to come down to at least 85 kilos, 84 kilos with the agent. And that is, we've never seen that before with any treatment till injection semaglutide came. Of course, some injection semaglutide, though it's not available, people are taking it, and there are many people taking it now, including tirzepatide. So one problem with these injections, our goal is not mindless weight loss. Our goal is weight loss with health. Remember, there is a rule of 4. If anybody loses 4 kilos, 1 kilo is going to be lean body mass. So you have to actually make sure that your patient is not just losing weight. So this is a patient on semaglutide. The weight initially came down from 114 to 60 after bariatric surgery. Subsequently, the weight increased to 83 kilos. So then when semaglutide we started, in 3 months the weight came down from 83 to 78. But the important thing is that many of you know that we now have a wellness center which focuses on health, and you can see that what we achieved is not just weight loss. The weight came down from 83 to 78, but the skeletal muscle mass has actually improved. The percentage body fat has come down. Though the muscle mass is still on the low side, The important thing is to prevent sarcopenia by appropriate protein intake, good fasting and strength training. Now there are newer drugs which are combining semaglutide with a molecule called activin inhibitors. They are called activin myostatin inhibitors. The key molecule is bimagrumab, and when you combine tirzepatide semaglutide with bimagrumab, people have what is called fat selective weight loss. You lose only the fat and you gain muscle. It activates the mutations. The myostatin gene actually causes atrophy of muscle, and when you block the myostatin gene, the muscle undergoes hypertrophy. So these are agents which are monoclonal antibodies that block it, and these agents are now being tagged on to anti-obesity drugs. So this is the goal, health, not just mindless weight loss. Now coming to tirzepatide, which is the flavor of today because it has just become available, important to remember that GLP-1 is produced from the L cells, but you have GIP produced from the K cells. So it's not just GLP-1, GIP is now regarded as probably the more powerful ingredient. We thought GLP-1 was a powerful ingredient, but it turns out GIP is a more powerful ingredient. And it depends on how the pancreas processes it, which pattern of enzymes. If you have PC2 prohormone convertase 2 activation, you get glucagon. But if you have PC1 and 3, you get GIP and GLP-1. So two important points to remember about GIP and GLP-1. So GIP was discovered as a gastric inhibitory peptide. Now the new name is glucose dependent insulinotropic polypeptide. But the name gastric inhibitory peptide is wrong because the one thing GIP doesn't do is act on the stomach. It doesn't act on the stomach. GLP-1 acts on the stomach, the adipose tissue and on the brain. But GIP doesn't act much on the stomach. But the other important thing to remember between GLP-1 and GIP is that GLP-1 reduces glucagon, whereas GIP increases glucagon. Now that's very paradoxical. We thought that glucagon increases blood sugar. How can you use a drug which increases blood sugar for obesity with diabetes? It turns out that glucagon is also important in weight loss. How? Because it causes activation, beta fatty acid oxidation in the liver and breaks down fat and a host of other mechanisms. And because it breaks down, it allows fatty acid oxidation, the beta oxidation of the fatty acids, you will see that it really reduces the liver fat. The other thing that happens is because glucagon, the action of glucagon, the glucogenic action of glucagon is blocked by the obesity reducing and glucose reducing action of GLP-1. So GLP-1 blocks the glucagon like action, it overcomes it, and the overall effect is good glucose control. Now tirzepatide has got another very significant thing. It is a dual GLP-1 GIP antagonist, but it is more, structure is similar to, not to GLP-1, structure is similar to GIP. The receptor binding is stronger to GIP. The pathways therefore favor GIP over GLP-1. One of the reasons why this molecule was developed is when you keep on increasing GLP-1, the patient is not going to be able to tolerate it. There is gastric problem. You all know, you give semaglutide, people will have nausea, vomiting, diarrhea. But because of GIP, there is an anti-emetic action of GIP. So that's one way it works together. So, and the second thing is GIP doesn't act on the stomach, it has stomach independent action. The third thing is the GLP component of tirzepatide produces very early tachyphylaxis to the gastric emptying. So because of that, the effect of GLP-1, the good effects are harnessed without the side effects. This is a structure and it shows how well it acts on GIP and GLP-1. And it has a half-life of about 5 days. So you can inject it once a week and the patients will do very, very well. And as I said, it's a man-made imbalance because it is favoring the GIP more than the GLP-1, and it also favors a particular pathway of GIP. So now I'll just show you the data of this molecule. This is tirzepatide on body weight, and you'll see that the weight loss is as much as, this is a SURMOUNT-1 study, showed the weight loss of 22%. But what is interesting is the weight loss continues. There is no plateau with this drug. If you keep on giving it, if you see the 2-year data, the weight loss is 25% and still going down. So the weight loss doesn't seem to plateau unlike semaglutide, and it keeps going down. Yes, there are problems. It should not be given in depression. There is a risk of suicidal ideation. The drug, there was some evidence of worsening of retinopathy. There is a risk of non-arthritic ischemic optic neuropathy. We shouldn't be giving it in people at risk of thyroid cancer. So it comes with all these bells and whistles. But despite that, the weight loss is something we never saw before. Let me show you one more drug called orforglipron. So orforglipron is a drug which is like semaglutide, but you don't have to take it on early morning on empty stomach, and the weight loss is as much as injection semaglutide. So there is a pill, oral orforglipron, which gives you as much weight loss as injection semaglutide. Remember, oral semaglutide gives only 6 kilos weight loss. Injection semaglutide gives 15 kilos weight loss. Orforglipron is going to give you a tablet which is going to give you 15 kilos weight loss. In a 100 kilo person. So about 15% weight loss. This is the bigger molecule called retatrutide. So retatrutide is an agonist of GLP-1, GIP and glucagon. So it acts on all the 3 pathways. And here the weight loss is at the end of 48 weeks, 2 years, the weight loss is already 24%. So with each drug you are getting better weight loss, and this is another one called cagrilinotide, which is an amylin analog. You get 10% weight loss in 6 months. Semaglutide will give you 17% weight loss in about a year. So the scientists thought, why not combine the two? So this is also another agent which at the end of 20 weeks is giving you 17% weight loss. Now I'll just show a case. A 23-year-old lady, she tried her best to lose weight, but she could not lose weight. The weight was 89 kilos, the BMI was 35, and we started her on tirzepatide, and you can see the increasing doses. You can see the dose, initially it started working very slowly. The BMI was 35, it came down to 34.8, and when the 7.5 mg dose was reached, she started losing more weight, and I think the last we heard she was at 32.3. So pretty good weight loss which will continue. And in the same patient also you can see the skeletal muscle mass was well maintained, so it was not it was not at the cost of sarcopenia. So these are my last 2-3 slides. So how to think about these molecules? This is a philosophy, not a molecule, is that these are single molecules that act on multiple receptors. It depends on what you want to get out of the molecule. If you want the predominantly GLP-1 action, it will suppress glucagon, it will increase the insulin, and you will get weight loss. So all good. If you want GIP action, it can increase the glucagon, good, because you lose weight. It can increase the insulin, but some white tissue expansion may be seen, which is very minimal and which goes away. The third is glucagon. It will increase the sugar, but it will cause energy expenditure and weight loss. So the trick is to make a molecule which acts on all these 3 receptors, giving you the benefit of eventual weight loss for the patient. So if you get only the good parts of all these molecules, so you have a single molecule working on all these post-receptor pathways to give you the benefit. And many people ask this question, which I find very silly, that once these drugs have come, what will happen to bariatric surgery? Nothing will happen to bariatric surgery. Dr. Shashank Shah will continue to rule because bariatric surgery, now we have more choices. Earlier you had diet, exercise, then you had bariatric surgery, you had endoscopic procedures. Now you have Dr. Rakesh is going to show you excellent and more futuristic endoscopic procedures, and now we have some medical treatment also. So now obesity has become a disease with a full spectrum, and this area where patients were not willing for a procedure but not able to lose weight following diet. And I think I want to end by showing this slide. This shows, this is our paper again, the same paper I showed earlier, shows that the higher the obesity, as the BMI goes up, the risk of new onset hypertension goes up and the risk of new onset diabetes goes up, and this was statistically significant. Again, this was a study of nearly more than 20,000 patients. Many of you know that we are doing our rural diabetes program. So this is from that program showing you that obesity is associated with new onset diabetes and hypertension, and we are all aware that the treatment for diabetes is weight loss in many people. Even in people with a normal BMI, there is a concept of a personal fat threshold. So I think we are in exciting times. We have all the treatments. But I want to end with a quote by Mark Twain. He said, the only way to remain healthy is to eat what you don't want to eat, drink what you don't want to drink, and do what you should not be doing or you don't want to do. So eat what you don't want to eat is healthy food, fiber-rich food, good food. We like tasty food. Drink what you don't want to drink means drink water. And do what you would not rather do is exercise. So you have to do all the difficult things in life to be healthy. But everything comes at a price. Even if you follow diet and exercise, you are actually struggling with that diet and exercise. There is an emotional component. So everything, patients ask, sir, ये bariatric surgery का side effect क्या है? ये injection का side effect क्या है? Endoscopy का side effect क्या है? I said even diet and exercise has got a side effect. Many people become sarcopenic after diet exercise. Many people get hypoglycemia after following 2 meals a day diet. Many people have injuries in the gym. It's a cycle, the more you gym, the prevalence of injuries goes up. So everything has got a side effect. There are nothing called, you get only the benefit. ऐसा तो जिंदगी में हो ही नहीं सकता. So I think there's a balance. But today, because of all this, our patients are happy, they're doing well, and we have something to offer them for their weight. Thank you so much for listening to me.
Thank you, sir, for a philosophical and an enlightening talk. I request the chairpersons to proceed with discussion.
Okay, excellent presentation. I must say, I wish we had someone like you always to present when we were presenting these for bariatric surgery 20 years back. But very good presentation, and I think this is a very good era where we have everything available for patients. So 2-3 questions for maybe new physicians who would prescribe.
Yes.
You mentioned some reports of non-arthritic optic neuropathy, and unfortunately it should not happen that someone prescribes in India and gets it. Do you recommend ophthalmic screening as a medical legal safety for those with diabetes, obesity, smoking, at least just to have a document?
I think that's a very good question. So you are aware that this drug can worsen the risk of diabetic retinopathy. So do not give it in people who have diabetic retinopathy which is unstable and requires a procedure. Any degree of retinopathy is not a problem, but if it is unstable requiring a procedure, no semaglutide, no tirzepatide. Second, what sir said is a very important point. If the patient is diabetic, he should have had a retinal screening in the last 6 months or 1 year. If he's not had it, you please tell them to do it. Though they say that the degree of sugar control is worsening, the sudden HbA1c control is causing retinopathy, we really don't know. The third is a question you asked about non-arthritic ischemic optic neuritis. So this is a recent paper that came out, and it showed a slight increase in risk with GLP-1 receptor agonists. So it's a very slight increase. It's a study of a large number. So in both numbers, the numbers were small. The number needed to harm is something like 10,000 right now. So 10,000 patients have to be treated to get that. If 10,000 people are treated, you may get that 1 case. So it's very rare, but it's important to explain to patients that it can give some eye problems also. Better to tell them before rather than rushing with therapy. I think because this is an expensive therapy, we need to discuss everything and then take a call.
It is an irreversible blindness, right?
No, it usually recovers and the prognosis is good, but a slightly statistically increased risk, and the outcome is very good. But still for the patient, that optic neuritis is extremely traumatic, worrisome. So I think we should tell them that there is a rare possibility, but without scaring them because it's very rare.
Yeah. Similarly, I have two more questions.
Sir.
Many patients with obesity are on some or the other medication for their psychological or psychiatric illness. So before starting these medication, is there any recommendation of psychiatric clearance or psychological?
So, my understanding of this is that many people are obese and are on treatment for depression. Some of them are depressed because they are obese. Some of them have depression because depression coexists. But if somebody is severely depressed and there is a history of suicide or suicidal ideation, so severe depression, clinically severe, the patient is clinically depressed, has got crying spells, suicidal ideation history, better keep away from the drug. In fact, yesterday only a patient had come and wanted to start tirzepatide, and I asked this question, and then I understood that she was not an antidepressant, but she had stopped the antidepressants and she was having crying spells. I said, no, we are not going to start it for you. So these are early days of the drug. We should not take any risk and start it only for the real patients. But as I said, we should not have panic also.
Sorry, the last question, and I think that is relevant more to gastroenterologists. So these drugs delay gastric emptying. Some reports of gastroparesis also exist. So food remains in the stomach for a longer time, and all these patients with obesity have some grade of reflux. Reflux is very common. Are we looking at more incidence of Barrett's in the long run? Because in the clinical trial, this
More
was
incidence of?
Barrett's esophagus
Barrett's
because
esophagus.
of reflux and acid in the esophagus. This was not a part of any clinical trial of this drug, and that remains an apprehension, maybe more for the gastroenterologist.
I think one of the important things is that this drug, what we tell our patients is that the gastric symptoms occur usually on initiation, and the second time it occurs is when you intensify the dose. These are the two times when it occurs. So I always tell my patients, whether it is semaglutide or whether it is tirzepatide, is that in the first 1 month, try not to eat anything that can irritate your stomach. Try to eat small frequent meals. Sometimes and very aggressive exercise after eating will increase the reflux. And of course, give all the important anti-reflux measures that we physicians know, like putting the head up, taking some proton pump inhibitors or other drugs, and manage it. And second time it happens is at the time of switching. And that is also something to remember with these drugs. The other thing is that with GLP-1, the tachyphylaxis is there. So usually it is shorter. With tirzepatide, it's even shorter because GIP acts as an antiemetic. I want to add one more point, which I forgot to mention. The side effect is that if your patient is on oral contraceptive agents and is taking tirzepatide, there is a slight chance that the oral contraceptives may fail at initiation or at dosage change. So during these times, we don't know exactly the reason why it happens. There is some theory about how it is binding and how it is acting and availability. But during these times, you should tell them to follow barrier contraception. This is something important if they are on OC pills. So in the net, you will find something called Ozempic babies, where many women who were obese and had given up on pregnancy with PCOS, they started this drug. And they started without knowing, they became pregnant also. Though they were told not to become pregnant, this is a new drug. So this drug can potentially increase fertility by itself also, these GLP-1. Because the weight loss is good, the cycles become better, PCOS goes away. So we should tell them not to become pregnant on this drug. At present, there is no evidence to say yes or no if they become pregnant, despite you telling. What to do, we don't know. But right now, better to tell them not to become pregnant on this drug. It's a very good question. It's a very good question. So the risk factor is medullary thyroid carcinoma and multiple endocrine neoplasia syndrome. Unless these two are there, you don't have to worry. Even a routine thyroid cancer, we really don't have to worry. But just to be safe in early days, we should keep off. But I don't think there's no need to do thyroid screening. We can clinically judge, do a simple clinical examination and go ahead. But these two things, medullary thyroid carcinoma, family history of medullary thyroid carcinoma, multiple endocrine neoplasia, don't use the drug if you suspect these things. Of course, pancreatitis goes without saying, we should not be using the drug. Yes. So there is a study like that. So the drug was given for 2 years. So initially they gave tirzepatide to all the patients for 36 months. Then at the end of 36 months, they divided into 2 groups. One group they stopped the drug, other group they continued the drug. The group which continued the drug, at the end of 2 years, the weight loss came down from 20 to 25%. The group which stopped the drug, the weight increased by 9.5 kilos at the end of 1 year. So they gained half the weight at the end of 1 year, which is actually not bad because there is some legacy effect. At least for 1 year, they have not gained the full weight back. But I'm sure that eventually they will gain back. So there was an editorial on this in JAMA. They said, why not use intermittent GLP-1? And there is a theory of micro dosing, small doses, because of the cost. But I think these are not standard yet, and these are just theories going around. But there is some evidence of a very mild legacy effect.
This is a little bit of a philosophical question.
Please.
The pie is getting divided between endocrinologists, gastroenterologists, surgeons, physicians. So do you think we should evolve into departments of metabolism, probably something like your institute? So where do you stand between the current care that you're giving and a department of metabolism? I mean, should every hospitals follow some kind of a model like this, which would be a better thing in the long run? Because we have to cut the flab. Everyone wants a dietitian. Everyone wants, what do you think about this?
I think there is a good scope for a metabolic medicine. I think that is a good area to work on metabolism in general. In fact, one of the people doing fellowship in diabetology at our hospital, he says, I came here to learn metabolism. That's also the goal behind the wellness center we started, where we look at lifestyle changes. But if you look about these molecules, I think these molecules can be prescribed not just by gastroenterologists, physicians, endocrinologists, bariatric surgeons. They will be prescribed by orthopedics, they will be prescribed by sleep specialists, because obstructive sleep apnea is a big problem. So I think these are going to be general drugs. But in the initial years, we as endocrinologists, physicians, gastroenterologists, bariatric surgeons, we must give leadership and educate everybody about this. But I strongly believe that no drug should be restricted, only endocrinology. For example, there is an insulin called Lumjave, which is an ultra rapid lispro insulin. As per label, only endocrinologists can prescribe. But I think these should be, everybody should be able to prescribe, and I think let the patients get the benefit. So it's not a molecule for, say, endocrinologists or specialists, but for the patient, and anybody should be able to use it.
It's like HLT2 inhibitor. Is that?
So the same thing, SGLT, it's a molecule of gastro, nephro, cardio. No, it's a molecule for the patient, and anybody should prescribe to the patient who's getting benefit.
So what's with Viagra? Initially it was supposed to be prescribed for only endos, urologists and psychiatrists. Now they will be prescribed.
So,
Right now, I don't think there's a regulatory thing like
no,
that.
there is no. And just to add a practical comment to that, that tirzepatide now is available in a vial form, 2.5 and 5 mg only. So right now the maximum dose that we can give to our patient is 5 mg. The higher doses are not available, and it's not available in pen form the way we are used to. So we are supposed, we need to educate the patient to take it with the syringe, which...
Well, I agree, but it's
not
very
difficult.
simple to take. It's
not
very
difficult.
simple to take, and you can always, if you want to escalate, you can use the 2.5
and
plus
twice.
5 mg together.
Yeah.
But they say that we should not divide the 5 mg into 2 because
cut
the
the cost.
injection doesn't have a preservative.
Right.
But
So once
I'm
opened-
sure that in India, many studies will come looking at thermostability and things like that. Yes, you can. In fact, that is when this diabetic retinopathy VEGF inhibitors are so costly. We used to call 4 or 5 patients together and give VEGF inhibitors to everybody, so that that benefit gets to it is divided and given to everybody. So I think in India, we are a poor country, let's face it, though we are becoming prosperous, and we have to think about the poorest of the poor and manage the situation.
And in real world, actually, the weight loss with 5 mg is not very, very less compared to what happened with 10 or 15 mg.
Well, it's slightly less, but it depends. You can stay on 5 or you can decide to go down. But I agree with you that let's prescribe 2.5 and 5.
Thank you, sir. I request Anjali ma'am to felicitate sir.
Dr. Anjali worked with us for some time, and pleasure to receive it from her.
Oh. I think there's a recording.
Oh.
I request Dr. Nachiket to give a small memento to all our chairpersons. So after this slightly philosophical, more practical discussion, we head to the next part, which is very exciting. Metabolic endoscopy, present and future. I invite our chairpersons, Dr. Vinay Thorat, Head of Department Gastroenterology, Poona Hospital and Research Center, and Honorary Consultant at Sassoon General Hospital. Dr. Jayashree Todkar. Madam is again a laparoscopic, bariatric, and metabolic surgeon. She is the director at Indian Institute of Metabolic Sciences. She has received multiple awards on her research in metabolic surgery. Dr. Harshe, sir is yet to come. Dr. Lalit Shimpi, sir. Sir is a consultant senior gastroenterologist at Jahangir and Dinanath Mangeshkar Hospital. He's practicing at Bhandarkar Road since 18 years. His interests include relief of malignancies, palliative relief of gastric malignancies. We welcome you, sir. Dr. Nachiket, I request you to hand over small mementos. I request Dr. Thorat to introduce our speaker.
Thank you. Dr. Kalpala, of course, very well known Rakesh in gastroenterology circles. Anyone who is in gastroenterology and has not heard of him is not attending meetings or is not reading journals. He has been awarded Young Investigator Award, Dr. B.J. Vakil Prize, and he is also fellow of two very choosy societies, American Society of Endoscopy, as well as the Japanese Society. He is the director of AI and endoscopy, and more specifically metabolic endoscopy at the prestigious Asian Institute of Gastroenterology, which is the largest GI hospital probably in the world today. So you can understand, at such an young age, he has been able to achieve so much, and many things to his credit, but I don't want to cut into his lecture time. One more important announcement is that we are very serious about this business of weight loss, so there is no dinner afterwards. So please go message your wife that you please make something.
Okay. Thank you,
They may
sir,
insert balloon
for those
instead, I
kind
guess.
words coming from you. So I thank Nachiket for having me here. And after the endocrinology talk, it's pretty easy because I thought there'll be a bariatric surgeon talk also after me, but you stopped there.
They made us sit here perpetually.
Okay. So initially I thought I'll just talk on metabolic endoscopy, but again after discussing with Nachiket, I thought let's have diabetes, obesity, and fatty liver also covering. So we all know why we are here is the greatest pandemics after COVID or this obesity, diabetes, and MAFLD, what we call now, it is NAFLD NASH. So as Dr. Unnikrishnan told, I think what we have to see, all the people here, all esteemed audience in this, are all physicians, senior physicians. So if any patient comes to your clinic, you say weight loss, you lose 25, 30 kgs, he'll never see you back again. Like, what the hell is this doctor telling me, khate pite ghar ke hain, aana hi nahi wapas. So you should inculcate into them a rule of 10 or rule of 5, what you call. 10% weight loss is good enough. You say, boss, you just lose 10%. If you are 100, let's come to below 90. That's your target. That is something which will get into their minds and then they'll inculcate it. If you say you lose 25, 30 kgs, they'll never do that. Because that's got a positive effect from head to toe in every organ. As he pointed out rightly, diabetes, hypertension, obstructive sleep apnea, osteoarthritis, sexual dysfunctions, and fatty liver, of course, so on and so forth. So, if you see these two branches of orthopedics and cardiology, last 20, 30 years, arthroscopy and interventional cardiology took a middle seat. So likewise, in patients with obesity or diabetes, we as endoscopists with my esteemed colleagues on the stage and off the stage, we believe that in between lifestyle modification and pharmacotherapy versus Shashank Shah and co, we have where we come into as a kind of a bridge between, and it's a holistic approach. We are not competitive to each other, we are complementary to each other. That is a take-home message. This is a very good article published in Nature in 2022, if you see this. So if you see the top brass of arrow marks, so the lifestyle modification and pharmacotherapy, so this is what it is, and the people who come on to the operative table with for bariatric surgery is hardly 1 to 2%. So what I am trying to tell you is there's a lot of lull and vacuum in between this, and that's where the endoscopic therapies are going to have a big leap in the next 1 to 2 decades. I'm not telling it as a anecdotal statement, but we have established literature on this. So if you see bariatric endoscopy in 2025, these are all what we have. We have the gastric space occupying devices, the endoscopic suture gastroplasties, and something including the duodenum. I'll come to that in the next few slides. So what we do primarily when it is something doing at the gastric level is you will have weight loss predominantly with an indirect effect on the metabolic parameters. But when you do something at the small bowel, that is duodenum, you have metabolic effects independent of weight loss, but there will be some amount of weight loss. So if you see the endoluminal restrictive procedures, what we do like surgeons, is you have the intragastric balloons as well as endoscopic sleeve gastroplasty. Balloons, I think you must have heard of them and from past few decades. The two currently available balloons in the Indian market are the Orbera, which is a fixed balloon, and Spards balloon, which is a adjustable balloon. I don't want to go into the video because it's a little time taking. So Orbera balloon, we have established evidence of good weight loss and also improvement in the metabolic parameters in terms of fatty liver. But this is adjustable balloon which is there from past couple of years. The advantage of this against the non-adjustable balloon is balloon once you put, then if the patient is not tolerating, then you have to take it out in 2 to 3 days. And that will give a very negative, unpleasant effect. And also not only in terms of symptoms, but also financially, because you're going to put in a balloon and take it out, which will cost 1.5 lakhs. So this adjustable balloon, the advantage is you can upsize or downsize the balloon. If the patient feels he's intolerable in the first 2-3 days, call him back, take out 50-100 ml, and then try to give him a little bit of time. And usually most of these procedures or even the drugs, what happens is they reach a threshold of weight loss. After that, they don't lose weight more. So in those cases, you can upsize the balloon by calling them back after 3 to 4 months by around 100-150 ml. So that will give you further more weight loss. So coming to the metabolic endoscopy, because we have the esteemed gastroenterologist here. So this is one study which we have done with this adjustable Spards balloon where we adjusted it by upsizing or downsizing. And we did a paid US liver biopsy in these patients. And we have authentic evidence with the liver biopsy where we found significant improvement in the steatosis and partially in the fibrosis, as well as, of course, the weight loss and all the other metabolic and cardiac parameters which we are more interested as physicians and gastroenterologists. To summarize the intragastric balloon data, we have around multiple meta-analysis being published till now, which shows around 15 to 20% weight loss in majority of the studies. So the second important endoluminal gastric restrictive procedure is what Nachke probably is going to start in the next few months in this city, which is the endoluminal endoscopic sleeve gastroplasty. Currently, there are 3 available platforms in the world, but what we have in India is the Apollo Overstitch by Boston Scientific. POSE is something which is there in the US market, but not FDA approved, due for FDA approval. Endomina is a European device which is there in few parts of the Europe, which is CE mark. So again, endoscopic sleeve gastroplasty, I'll just run through a minute what we do, because there are many physicians who have no idea on this. So what surgeons do is they will do sleeve gastrectomy, where they'll chop off the greater curvature of stomach and make it a tubular organ. So what we are going to do endoscopically is we'll start suturing like this from the incisura level and then come up to below the GE junction. We are not going to cut the GE junction, and again the stomach will be a tubular organ, or a tubular accordion stomach, what we call. So the landmark study published on this device and this procedure is the randomized control trial in Lancet 2023 by Barham Abudai and other multi-center trial from US, where they have taken people who are in class 1 and class 2 obesity, that is up to 30 to 40 BMI, and then they divided into 2 arms, the sham versus the ESG, and where they have found significant improvement in the weight loss up to around 23%, the total body weight loss. And then they have crossover this sham or the lifestyle modification arm into the ESG arm, where they found again similar significant improvement. So again, this I am talking about the publication or the theory or statistics. What we are all interested as endocrinologists and physicians is this slide. So if you see this, in this you have positive effects in terms of diabetes improvement, metabolic syndrome, hypertension, HOMA-IR, HbA1c, hepatic steatosis index, pro-inflammatory markers like CRP, and the waist-hip ratio. So this is again a gold standard randomized control trial which we all look upon, and this has shown this. So similar study from our group where we have done ESG and then saw the improvement in the liver steatosis parameters, of course in a non-invasive way, where all these markers have found statistical improvement at 6 months. Just for you to understand or for your knowledge, this is again another platform which is used for gastros here. What we use is a dedicated platform called POSE, Primary Obesity Surgical Endoluminal. And the advantage of this is you need a pediatric scope compared to a double channel scope what you have for the Apollo Overstitch. And again, the weight loss results are similar to the Apollo Overstitch. Endomina is again another device which for our gastro colleagues you need in this simple upper GI scope, and you don't need any special scopes, but it is kind of a technician driven procedure. So this is one study which we are doing it with Jack Davier's group. We are doing again paired biopsy in patients with NAFLD-NASH with Endomina ESG. So again, you might ask, especially my colleagues, endoscopy colleagues here, why the hell I have to learn? Because it needs a lot of learning curve for these procedures. And Dr. Thorat will say, at this age, I don't have time to come and learn this in your institute. So for his question, we have an answer. There is an automated motorized endoscopic sleeve gastroplasty device coming from an Israeli group, which is tested in Spain and Rome on the humans, where you just have to put this device inside the patient's stomach, and it will just go and automatically suture. You don't have to do anything. So it will just suture it, and then you come out, load again, put in, suture, and come out. And there are results which are being published. Probably this device is going to overcome the learning curve and also make the procedure more simple. Of course, it is blind, but again, it's evolving. So that is what it is. So that's the second part of what I thought of endoluminal restrictive procedures, where you treat obesity primarily by weight loss. Coming to our fascinating topic, which as we as Indians and globally, diabetes, obesity, diabesity with fatty liver, anything on this. So as we all know, and with other endocrinologists sitting here, so what is being now hypothesized is that epicenter for metabolic control is the first and second part of the duodenum. It's no more the pancreas or the liver. Why? Because there is a theory or a physiology, if you go back to your medical school days, so you have the incretins and anti-incretins on the brush border of your first and second part of the intestine. And when you have a nutritious meal like what Dr. Vinay Thorat is mentioning, they have a balance in that. But Nachiket is ready to feed us with all the high calorie meal after this talk. So that's where when you have a sumptuous meal with high calorie, there will be an imbalance between these incretins and anti-incretins on the brush border of insulin, and that leads to insulin resistance, hyperglycemia, hyperlipidemia, and we all will land up in Chalaram Diabetes Center. So that's the reason why we have to do something at this level, and if you balance this imbalance of incretins and anti-incretins, that is where you can achieve this positive control. So our bariatric surgeons are way forward. From past 25, 30 years, they are doing this Roux-en-Y bypass and currently the OAGB or the ileal interposition. But unfortunately, 1 to 2% of the patients only come onto the table of Shashanksha. And most of them, they again search for alternatives, diet regimens, and so on and so forth, then pharmacotherapy. So again, this is the treatment gap which I am telling. And to go to the next part of the talk, which I believe personally, if you ask me, this is going to stay more than the other restrictive procedures in a long run. So one theory what you have to understand when you come back to the physiology is the foregut hypothesis and hindgut hypothesis. Foregut hypothesis is the proximal small intestine, if you impair the nutrients to touch the mucosa, that will prevent the anti-incretin secretion, which these surgeons do as Roux-en-Y bypass, or the hindgut hypothesis again, where they stimulate the insulin secretion when you exclude the duodenum and proximal jejunum. That is what is the ileal interposition. So we as endoscopists started working on this, and then we have some established devices. Of course, they need a little more evolution to come in the next 6 months to 1 year, I am sure. There is one thing called as endo barrier, which my colleagues must have heard of, where it is a device which is a liner which prevents these nutrients to get contact as a sheath which covers the first and second part of the small intestine. And there are studies which have been done on that, where they found significant improvement in obesity and diabetes and hepatic parameters. But again, this took a backseat, unfortunately, because this liner had barbs which were impending on the duodenum, leading to liver abscess. So unfortunately, FDA has withdrawn this device. So we at AAG started working with a similar model where there is a biflange pylorodduodenal stent with a polyteflon coated sheath which covers the first and second part of the duodenum. This is a company from Minneapolis. It's called Metamodics, where it's a very simple, easily deployed 25 to 30 minute procedure, could be done by an average endoscopist. And the results, what we have shown in the first 3 months is improvement in the HbA1c by 1.8% max and around 12.6% weight loss. But it was not that rosy as it looks, because it started migrating into the small intestine. So we went back to the bench side and then did a pyloric sphincter. See, the most robust sphincter in the body from top to bottom is the pylorus. It has got so much of contractions. Anything you put there, it will just gush into the distal small intestine. So then we did the endo flip on that, and then we estimated the pyloric sphincter physiology, went back and then redesigned the stent. And this is how exactly it looks. I'll just run a little faster. So if you can see, we put in a guide wire, and onto this, we mount this device, which I'll show you in a human model rather than an animation. So this device goes inside, and then we'll first deploy the duodenal part flange and then the pyloric part. And in the end, it looks something like this, where you have a stent with a PTFE sheath covering the duodenal mucosa. And as I told you, it started migrating. So we use the same Apollo overstitch, and then we have made 2 stitches, putting an anchor on the device. So now it's completely stabilized, and from last 6 months, we did on 5 cases where we have found very good improvement. And the end of the procedure, it looks like this, which Shrimpy and Thorat will appreciate how exactly the anatomy looks. So the results, as we have of course shown 1 patient, but we have 5 till now, where the HbA1c improvement is almost by 2.3%, and the weight loss is around 10 to 12%. Within 3 months, we explanted this device, but otherwise this device is meant to be there for 6 months. It hardly takes 15 to 20 minutes to deploy, 5 to 10 minutes to explant. And the advantage of this compared to the restrictive procedures is the patient can take the normal diet. They don't have that fullness. But again, it won't get absorbed there. Like what the drug does, this is going to do, the device. Can I have some water? So then endoluminal magnets, this is something which is again experimental. I'm not going to go into that. But the next one is something which is very fascinating, and I believe strongly that there's a lot of work happening and this is going to stay. Instead of putting all these liners and all, you ablate the mucosa, simple, with one of these techniques like laser, RFA, electroporation, steam, any of these energy emitting techniques. The established technique till now is by a company called Fractile from US, where of course they have done this duodenal mucosal ablation using a hot water at 90 degrees, which is a little crude technique, but most of the literature has come up on this, where they put in a scope, inflate the balloon, and then start ablating the mucosa with simple hot water, and that leads to charring of the mucosa, and it exactly looks like this. And after 3 months, by 3 months, the mucosa gets healed. But as Dr. Unnikrishnan told, there is a mechanism where the enterochromaffin cells, the GIP and GLP-1 analogs balance is created. And there are established studies on this which are published again by peer-reviewed journals like Gut and other, where they have found improvement in the HOMA-IR, all the parameters what I have told, and even improvement in the hepatic steatosis indices and also the other parameters. But again, there were incidents of 1 to 2% strictures because it is a little crude, and then still they are working on, FDA didn't approve, but they are in the process of approving it. And for our gastro and hepat colleagues, again, the same thing has been done on the patients with NASH and NAFLD. So this is again a very fascinating duodenal mucosal ablation, where surgeons use actually is electroporation technique for ablating tumors in liver and pancreas. So we as endoscopists started doing this with a special device called electroporation generator, where it is a over the scope, where exactly goes into the second part of duodenum, then it opens up, it creates a 360-degree circumferential mucosal burn or charring. And sorry, I didn't check the video. So this is how exactly it looks. I'll just run through a glimpse to understand how it does. And it will give a 360 degrees charring that leads to the same mechanism, but unlike the hot water, it is more refined. And the studies again on this have shown similar results. There are more to come. They have a 1-year validation studies by Netherlands group and the US group. As you see here, significant improvement in both the diabetes and weight loss parameters. And for us as hepatologists, more interest is in the steatosis, liver fat, where in this study by American group, we have found at baseline to the end, around 1 year, they have around 2.8% decrease, 23 to 2.8% liver fat improvement. So we at AAG started doing the similar thing, but it's a little confidential because we are doing some back-end experimental studies with a through-the-scope device with the same electroporation technique. So the ideal duodenal ablation technique should be something which is through the scope, less than 30 minutes procedure duration, daycare, and average endoscopists can do with a very minimum amount of affordability and economically easy to do. So the efficacy of this duodenojejunal bypass liners or the ablators is you have improvement in the diabetes, weight loss, as well as cardiometabolic parameters. So just to summarize, we as endoscopists have got this endoscopic, bariatric endoscopy to stay there for a longer run. And even in patients with lean NAFLD or NASH, also the DMR technique is going to have a multiple benefits. And this is what we are doing at this level in the world, where all this is the mechanism of action which happens, and these are the ones which I told at the stomach level, and the other ones which I told at the small bowel level. So just to summarize, this endoscopic bariatric metabolic therapies, weight loss obviously is the first approach as told earlier, improvement in the MASH parameters, And as I told you, it's all a combo therapy, and there is no competition. Again, I'm re-emphasizing it's only complement, where, for example, I'll tell you a scenario, a patient with a BMI of 35 to 40. So he or she comes, they are binge eaters, that's the main thing. So you do one of these balloon or sleeve gastroplasty, or you put these liners, or you do one of these and super added with this one of the pharmacotherapy agents. So this will give you a double whammy effect. I'm not saying that it's going to replace bariatric surgery. Bariatric surgery has got its own role. Above 40, obviously, they are not patients, I mean, BMI above 40, they are not patients whom we have to experiment in all this. But between 30 to 40, class 1, class 2 obesity, there's a lot of, holistic approach with which we can treat these patients. And we as doctors here, necessity is the mother of invention. And this is never a one-man show or a one-woman show. It always should be a multidisciplinary team approach, as it was told by Dr. Sanjay Salunke. I would sincerely, strongly recommend that if at all you want to start a center with bariatric program, of course, Dr. Shashank and all they have, you have a holistic approach, start a metabolic clinic and have all our peer people, because not only these endocrinologists, gastroenterologists, hepatologists, bariatric surgeon, but you need referrals, and they come from these guys. For PCOD, gynecologist, TKR, orthopedics, then cardiologist for OSA, ENT for OSA, and all those things. So they are all people who will refer, and it will be a one-stop shop where one patient with obesity, diabetes comes, and then they are seen by all these people holistically and give a genuine, unbiased suggestion. So with this, I'll end, and with the permission from chair, if anybody coming to DDW, so this is a ABE course which happens every year, and this year we have 23 faculty across the world, which is we are doing it in a very novel way, where you have a glimpse of the entire endobariatrics, what's happening across the world. Thank you for your attention.
Thank you, sir. Today's both lectures have sort of opened the Pandora's box, and so many novel approaches to treat obesity. So I request the chairpersons to proceed with the discussion.
Thank you, Rakesh, for an excellent lecture and an overview on what endoscopists can offer at present as well as in the future. So I had a couple of questions just to start or let the ball roll. At what stage do you, when patients come to you, at what stage do you advise them to go in for an endoscopic therapy? Because that is a question that probably will come from the audience. Or when do you decide, okay, let's stop with the pharmacotherapy or with the exercise, weight loss, and when do you say that, okay, this is the maximum achievable and now I want to offer you? And the second question was, of course, are there comparative studies between gastric sleeve surgically done as well as endoscopically done, and how do they fare in comparison with each other?
Okay. So coming to question number one, I would say you have to be wise enough to choose the patient for bariatric procedures. She will agree with me. Any patient who has got a binge eating, obviously, obesity is a chronic relapsing disorder, especially in people who want to start the bariatric program, people like us, because for them, they are all giants in the field. So for us, it should be, as I told you, one, a departmental, multidisciplinary approach. Second, binge eating people, even if you start on pharmacotherapy or do a bariatric endoscopy, probably they will have, short-term gain, but long-term we have to see. And for choosing the patient whom you will suggest bariatric endoscopy, obviously the contraindications, what he has told, they are for us in terms of not starting the pharmacotherapy at this juncture. Second, motivated patients who wants to lose weight. So as a double whammy effect with these drugs being there, anybody who comes to OPD, they'll ask you first question, doc, why can't you take the pharmacotherapy? Why this? So in those cases, we have to give that explanation. And third, in fact, what I see in my personal experience is when our orthopedic colleagues or the liver transplant colleagues, they refer for a faster weight loss. In those patients, you push them either for a balloon or an endoscopic sleeve gastroplasty. And the second question, comparative studies, there are no head-to-head comparative studies, but I will tell you which Dr. Shashank will agree, or she'll also will agree, patients who have got lap sleeve gastrectomy and their quality of life, if they have GERD, that is terrible. So the advantage of bariatric endoscopy, of course, again, quote unquote, I am not crossing below, above BMI 40, between 30 to 40 BMI or 30 to 35. That incidence of GERD is 0. Second, of course, leaks won't happen with the big bariatric surgeons, but leaks again is something which also is not there. So in that way, a set of people between the BMI 30 to 35 or up to 38 or 40, we have now an established role to counsel them for whom will benefit, whom won't benefit. That's what I mean to say.
Thank you. Any questions from the audience? Yeah, 1 second. Yeah.
So I have few comments and some questions. First of all, it was a nice presentation, no doubt about it, and we have to work together, whether we like or not, but we have to work together, that is true. About the GERD which you mentioned after the laparoscopic sleeve gastrectomy, initial days when we were not aware why people get reflux, the treatments and the problems were pretty much, like you said, disturbing to the patients. But now with multiple studies, with the manometries and the studies about the hiatus, gastroesophageal junction, and as well as the pylorus, now we don't make tight sleeves.
Correct.
They are pretty much lax at the below end, the distal end. And that is where the GERD is come down quite a lot.
Right.
So it has become a very better thing as far as the patient.
It's a large hiatus hernia, you do?
No, so if there is a lax hiatus, then we can repair the hiatus at the same time when we are doing the sleeve. But if it is hiatus hernia and a large one, then we prefer to go for a gastric bypass.
Right.
Then sleeve is not the thing to be considered. That is one part. Even in the SAGES guidelines, they have talked about gastric bypass to be done in patients with hiatus hernia, with obesity more than BMI 40. Not to do just the repair, hiatal repair, and come out, because the whole the intra-abdominal pressure invites the hernia again. So that is one part. The other thing, I have a question for you, is maybe the medicine also and the endoscopy also talks about the small bowel, the GIP, GLP, all those things. But here we are unable to cover in both the places ghrelin, which comes as a very strong hunger hormone.
Yeah. Right.
So when we talk about hedonic hunger, when we talk about binge eating, ghrelin becomes one of the strong parts. And I think bariatric surgery proves itself to be a better one still against all odds. Because we are treating, not that I am doing it, but this is something which is scientific. Okay. So ghrelin, which comes as a hunger hormone, which gets much better treated as far as the sleeves or maybe the bypasses, where we bypass that area from touching the food. That is one comment. So maybe you can tell me about
So actually we are working on it. And we, in sense, the endoscopists. So we are doing something called as gastric fundal revitalization, where we are doing a APC of the fundus, and there are studies coming out. That's the reason why we are trying to do something on the ghrelin. And the see what happens is when we do endoscopic sleeve gastroplasty, we don't touch the fundus. The fundus is left behind.
Exactly.
The theory behind that is that it will create an artificial gastroparesis. But now there are few people who are trying to ablate that residual fundus, which is untouched with ESG, and then trying to address the ghrelin part also. Of course, it's coming up. I don't have any telltale evidence as of now, but people are doing it.
So I was coming to that in the endoscopic gastroplasty, you don't touch the fundus. That is a big difference, I think. Okay. One question I had was, when you talk about the hot water ablation, what happens to papilla? What happens to papilla?
Yeah, so it's done proximal to the papilla, not distal to the papilla. So D1 is not done. It's done distal to the papilla. That's the reason why we put a clip and do down.
So you can be very specific in that.
Exactly. But now, off late, the studies on electroporation in US and Netherlands, what they have done is they are doing a little above the papilla, sparing the papilla and doing above it also. But fortunately, with electroporation, there was no incidence of pancreatitis.
Yeah, because when you showed it, something going in
Yeah.
and then inflating
Yes,
and
yes.
giving that
Yeah.
hot ablation,
Yeah, electroporation.
I thought it was in the D2.
It's beyond papilla.
Okay, okay. So
Distal to the papilla.
you may be very specific in action, I
Yes,
guess.
yes, yes.
I am not aware of that, so.
You could actually see that clip over there.
Clip, yeah, you saw it, no? Yeah.
And
So that's the
one
papilla
maybe one, okay.
Sorry.
You want to say something?
No, no.
Okay. One thing which I may like to say, you talked about endo barrier. So the people who did endo barriers, I was a part of the team in Sao Paulo, Brazil those days.
I know, yeah.
So maybe you can say with Almino and Galbao, I was working with them that
yeah.
time. Endo barrier was very exciting and we did a lot of experiments. But then we found that maybe we were clueless. Now we know probably about it, the enterohepatic circulations, the microbiota,
Yeah,
beyond the mechanical problems.
exactly.
There are a few other things which need to be addressed.
Yes.
And I guess there is a way to go, I mean,
Yeah.
to come to more standardization of the
Correct.
treatments.
So with our device, we are working on the gut microbiota also. We're just
Yes.
getting it.
Thank you.
Thank you. Usually, as of now, it's 6 months what we have tried. You remove the, you explant the device. So that we have to see. We don't have the data on that. It's just like a drug, you know. Stop the drug and then you regain weight. Yeah, yeah.
Rakesh, just one question. Which of these procedures protects the lean body mass loss? Which, all of them, and what percentage of LBM do they lose? So it likes, in drugs it is 25%.
Yeah.
In these procedures, how much? If you know that fasting and all those procedures, there is a drastic loss of LBM.
Right, right.
So with your procedures, what happens?
So I think as of now, the evidence is on the ESG only, gastroplasty. But I feel in a long run, once these duodenal ablations come, so that will have a better, so we have to see on that. We don't have a data on that till now.
So what are the costs of these procedures?
Shall I tell? Yeah. So balloon comes to around, the landing cost will for the hospital will be 1. So anything above that 1.2, 1.3 lakhs. ESG, if you put each suture and cinch, what we call, it comes around 35,000 to 40,000. If you put 6 sutures, it is 2.5 lakhs. 8 sutures, 2 more.
And these ablative procedures?
No,
or
they are
the-
not in the commercial market till now. Only the 2 are there.
So maybe I'll have,
Swallow balloons, yes, I don't have personal experience, but I am not very pro also. The literature till now is showing it's only a 4-month affair. It will lose around 4 to 6%. But again, after 4 months, you don't have anything inside.
I
my
think
question-
this will go like cancer, maybe.
Can't predict, yeah.
All three have to work together.
Yes.
Different stages, different people come in first, but everybody needs the other,
Yeah, yeah.
always.
No, I'm telling you, you have to have a metabolic clinic to have a success. In terms of multiple things.
My question on your metabolics, the duodenojejunal, that procedure. So that patient you described was also having anxiety and a binge disorder,
Yeah.
eating disorder, and
Yeah.
was also a note on antidepressants.
Oh.
So I think for those patients, this might be a very good tool.
Exactly.
And also, therefore, I think you described that the restrictive procedures endoscopically are coming down, and the distal procedures are now gaining more acceptance.
Yeah, yeah.
I remember when in the days, long time back, when the banding used to be done, people used to feel extremely hungry and they couldn't eat despite hunger. So I think these procedures, I believe that any procedure when you start off, there will be some limitation. Like it may have to be changed every 6 months,
Correct.
or that the weight loss may be temporary. But I think these innovations will soon produce much more lasting and better products. So that's my one point. And the second point is your view on the swallowable gastric pill. You didn't mention that, but your views on that.
You mean the
I know.
balloon or pill?
No, there's a swallowable gastric pill.
That's what we were discussing.
Yeah.
So you're bang on. Actually, out of these 5 patients whom we have done, 2 of them were females of the same. And I'm telling you, trust me, they all had much improvement in the psychological disorders. They were almost off the antipsychotics, both of them.
How long that vaporization effect lasts?
Sorry?
Vaporization effect, how long it lasts?
As of now, the data is on 1 year, where they have found sustained HbA1c loss. One year data is there. And so one more thing, why I'm telling you it's more promising is you can reproduce it. Probably after 1-2 years, once you can redo it again if there is no complication, I mean endoscopically.
Long time ago, there were a report of some 5 deaths with one of the balloons. Then it was unexplained, and then they found, of course, there are many reasons for these deaths, perforation and all that, but that never was seen in these 5 cases. And that was in one particular balloon company. But I think after that, correct me if I'm wrong, I think balloons and all procedures are largely safe. And there were no such issues.
See, they are all because of, as I said, perforations not deploying properly.
Thank you. I request Dr. Shimpi to felicitate sir. I request Dr. Nachiket to give the vote of thanks and for arranging this academic feast for all of us. Dr. Thorat has mentioned that there is no dinner followed, but there is dinner for all of us too.
Yeah, because the ghrelin levels are quite up now. So, good thing that the conclusion I think is that we are all complementary to each other and not competitive. That's the greatest message we can get from this CME. A lot of hard work went in while we did this, and we kind of conceptualized and all those things. So I would like to thank all of you for coming here. I would like to thank all my chairpersons, Dr. Thorat for constant guidance, Dr. Saili for being a good, wonderful master of ceremony. Datta Patki gave this catchy title of a pill for every pound. So I thank him for that. Our marketing team in Poona Hospital, Mr. Dave, Dr. Mehta, the Sun Pharma for being a generous sponsors. So as I said, after the academic feast, the real feast is waiting for us. Let's join for dinner. Thank you.